and this is our cohort coaching session number 7. We are still working through the Crisis Now mobile crisis outreach teams. Today, we're focusing on policy and procedure development with our wonderful presenter, Jamie Seller. So we are happy to have him back for session 7, and we are happy to have you all here too. I checked out names. I could see some repeat folks. We're happy to have you here. And for the new people, just so you know, the recordings for previous sessions are available for your viewing, as this is dynamic content that builds upon itself. We do appreciate all the information that you share through this process. It's extremely valuable to hear what's happening in the field. And so we invite you to engage in conversation as we proceed through our session today. I will start first with our disclaimer that this training is offered through the CARE TA Center, which is the Crisis and Recovery Enhancement Center. We are funded by the California Department of Healthcare Services and administered by the Center of Applied Research Solution, or CARS. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, and policies of the California Department of Healthcare Services, but we are extremely grateful for their support, which brings venues like this to the field. Thank you so much to them. So what is CARE? CARE is the Crisis and Recovery Enhancement TA Center, which I mentioned on the previous slide. We provide a comprehensive array of training and technical assistance services to California's Mental Health Service Act funded stakeholders and partners. Together, we work to strategically plan, effectively implement, and continually evaluate and improve on the behavioral health coordination and crisis response services that you all are providing in the community. Our CARE TA team is made up of partners, including the Center for Applied Research Solutions, RI International, also NAMI, the California chapter, C4 Innovations, also Impact Justice, and Stanford Sierra Youth and Families. Together, we work to provide TA and training, and those will consist of things like needs assessment, listening sessions. We have our annual conference, which is coming up on May 25th. We have our technical and training assistance. Also on our website, you can find our resource library, which you can search through fields and find information that's helpful for the work that you're doing. We have a quarterly newsletter and social media channels that we keep up to date. And we offer a 5 Things Need to Know digest, as well as cafecitos, which are small recordings on topics that are important in the field at this time. All of which is available on our website. So I encourage you to go over there and go through our website and see what you find there. As I mentioned, we are here today to talk about the mobile crisis outreach teams, and we are actually focusing on our policies and procedures today.
So I think I'll start by introducing myself, and I do know a lot of us have, a lot of you have been here with me for the past 6 or 7 of these that we've kind of run through. So my name is Jamie Seller. I'm a Chief Strategy Officer for RI International, which is a lovely title. It means I spend most of my time doing consulting, training, and business development. At my core, I'm an LPC. I'm a licensed professional accountant from the state of Arizona. Got my master's degree in '93. And got my certification in '94 and became licensed in 2000 when it became a requirement in the state of Arizona. And really, I love working crisis, facility-based crisis, mobile crisis. I like anything that's going to be short-term with a little bit of intensity behind that. When I was running the mobile teams here in Maricopa County, and I did that for years and years and years, we were running 24 teams a day, basically going out there, meeting people where they live, worked, and played. And really with very, very little, technically no exclusionary criteria, which means we would go out and see people who were intoxicated. We'd go out and see people who did not want us to come out and see them, that maybe a friend was calling for. We go out and see folks with intellectual and developmental disabilities. We were doing street level work. We believe that's what you need to be doing, is street level work, with the goals of keeping people out of jail, to keep them out of the emergency departments, to keep them out of higher levels of care, and really focus on stabilizing folks where they need to be. So basically what I'm going to talk today about is 2 things. I'm going to talk a little bit about the SAMHSA National Guidelines. I'm going to focus a little bit on that. I was fortunate enough to be able to be one of the writers for SAMHSA's National Guidelines for Behavioral Health Crisis Care that came out February of 2020. And quite frankly, I'm doing the writing over a lot of things, but really mobile teams is what I did most of the writing that I did for that particular process. So mobile teams are near and dear to my heart, and I do have a good understanding of policies and procedures. But what I know most about policies and procedures are that it is probably the least exciting thing that mobile teams do, is to have that focus on it. So let's go ahead and jump a screen, and we'll go ahead and look and see what the agenda is today. I'm going to talk a little bit about why policies and procedures are important. I think you guys know, but I want to go ahead and reiterate that, maybe get people excited about going back into policies and procedures. I want to go ahead and talk about the policies and procedures that you should have, or potentially that you should have. We've got high priority for policies and procedures, some moderate, and then some that kind of nice to have. Maybe I don't absolutely have to have them. But I do remember when I started, it's been 15 years ago, actually running mobile teams, trying to figure out what policies do I need, what policies don't I need, as you're starting to create these from scratch. And I think a lot of you might be thinking about creating some of these things from scratch. Just knowing what the topics should be, what the titles of those policies and procedures should be, I think is going to be helpful. I'm going to review 3 policies today that sometimes are a little difficult to create. These are policies that I've kind of created to support some of my technical assistants with folks that need to get their policies and procedures kind of up and running. So I've got a few generic, I've probably got a list of a few that are generic that kind of gets new managers or new programs kind of up and running and kind of feeling out how they need to go ahead and create those. And then some final tips on intervention. It says intervention timelines from seasoned professionals. It's going to be policies and procedures. I didn't cut and paste that one out. I apologize for that. So let's go ahead and move forward. I'm going to start really by talking a little bit about what policies and procedures are, because there is differences. Now, obviously, we talk a little bit about them being, policies, procedures. We have protocols. So understand that policies, when we talk about policies, we're not talking about directives. We're not talking about how-tos. Really what we're talking about is a set of guiding principles. It is our policy not to do this. It is our policy to do that. It's not going to be first we're going to do A, and then we're going to do B, and then we're going to do C. These are very overarching. So at the very least, you want policies to go ahead and direct what your culture is going to be within your agency. A good policy is it is our policy to see anybody, anytime, anywhere in the midst of a behavioral health or substance use disorder crisis. Now, the protocols and procedures are how I get that done. The policies, we're going to go. The policies, we're going to be 24 hours a day, 7 days a week. The procedure is we're going to have a schedule that's created and that the managers are overseeing that process. So policies, absolutely very generic, very overarching. You need to have them because it describes what your program is. Protocols are a little bit more problem oriented. They are going to be a little bit about how things get done, some of the rules, some of the regulations, some of the instructions on how the sauce gets made. And the procedures are going to be very much A and B. So I may have a policy that, peanut butter sandwiches are eaten every day. My protocols are every day at 4 o'clock, we'll be eating a peanut butter sandwich. My procedures are going to be, I am going to go ahead and get the bread from this particular cabinet. I'm going to go ahead and get the peanut butter out of that particular cabinet. I'm going to go to my drawer and I'm going to get a bread knife no longer than 4 inches. I'm going to go ahead and then open the jar with my right hand. That's what we're looking at. So if we look at this in kind of a bigger concept, you have a policy on vacation, determines how much you get. The procedure is going to list whether or not I'm going to approve your particular PTO request. And the protocol is how you submit that. So everybody has a policy about PTO, should have a procedure, should have a protocol. Now, what I do want to talk about in regards to policies and procedures are going to be this. I'm a clinician. Policies and procedures are the last thing I ever wanted to do. When I was in grad school, I was looking to stamp out mental illness, looking to go ahead and be able to diagnose and just do wonderful, wonderful things for my community. The last thing I ever wanted to do is sit in front of a screen and start trying to come up with a process of how something should happen and remember every step and really document it in a way that makes sense and that it's clear and that it could be understood at a 6th grade level. So it tends to be the last thing I like to do. And as we know then, what it means for many of you, if it's the last thing you want to do when you work crisis, it's never going to get done. Because there's always going to be some hot button topic. There's always going to be a crisis. There's always going to be some problem in front of you that needs to be solved. That really, if you're working crisis, kind of want to do a little bit more than policies and procedures, just like data collection and billing and regulation and audits, all of those things that you hate to do. Policies and procedures are going to be some of those things, but they're absolutely going to be important. So let's go ahead and move to the next slide. So we can stop there and then we'll start hitting buttons. So policies and procedures, I want you to know, and I'm going to put this 3 or 4 times probably in this slide itself, is policies and procedures are your. So as I go in and I have a discussion with folks that are running mobile teams, and I tell them to go ahead and define and describe their program, I get a lot of great words, but I should be able to take your list of policies and procedures and fully understand what you're about, what your program does, what your program doesn't do, where the consistency is, what you find important, what you don't find important. And overall, I should be able to take your list of policies and procedures, go through them, and create a fantastic narrative about what your program does. What it also starts to do is starts to create expectations for performance. So go ahead and click on the next slide, the next one. So the key on policies and procedures, once again, is I do think it creates expectation for performance. It creates consistency. It allows you as the leader of your department to go ahead and set the tone of how you want work to be done. Once again, what's important, what's not important, what needs to get done, what doesn't need to get done. And quite frankly, most of you, by the time you get into management, you're in a position that you're probably not doing a lot of actual teamwork, unless you get call outs. So really what you want is your policies and procedures are you on every call telling your team how to do things your way, having that consistency. It guides the day-to-day activities, it promotes consistency, reduces mistakes, and it does keep your clients and staff safe. I want to talk a little bit about promoting consistency, because I see this in all behavioral health agencies, regardless of the services that they're providing. I see it in some of the other standards for crisis work that we see across the country, those coming from other agencies that really talk about a lot of variability in how you perform your care. There's a big pushback that we don't want cookie cutter solutions. We don't want, to do things in one county the same way it's done in another county and a way in another county. I understand that, but you want to do the best practices, and the best practices are going to be the best practices. So I see this frequently when people do not have strong policies and procedures. Let's say you've got 4 teams. Let's say you got 4.2 teams because you're providing 24/7 coverage. Team 1 does great work. Team 2 does good work. Team 3 does okay work. Team 4 does something different. So if I sit there and I look at Team 1 and I say, Team 1 is doing absolutely great work, perfect work, everything that you would love in a mobile team. But Team 2 does it different. And Team 3 does it different than Team 2 and Team 1. Team 4 does it different than everybody else. At some point, what I can say is, I guarantee you at least a couple of those teams are suboptimal. They're not doing the best practice because they're not consistent. How can they all be different and one of them be best? One of them could be best, but not all 4 of them can be best, just by definition. So the better consistency you have by better defined policies, procedures, and protocols, you're going to be able to ensure that your programs are consistent, that the results you're getting from Team 1 to Team 2 to Team 3 to Team 4 are going to be consistent. And granted, there's going to be some variations. We've talked about strong staff and weak staff in the past. You're going to find some of those, but they're not going to be absolutely dramatic. Imagine if you went to McDonald's or you went to any of these chain restaurants and you weren't quite sure what the food was going to taste like. They strive for consistency. Here's what we want it to taste like, and we're going to strive for consistency so it's always this way. Mobile teams should be the same. On a very basic level, I am saddened if I think that a person is going to get a response to their crisis at midnight that is different than the response that they will get in their crisis at noon. The only way I could ensure that is having properly trained staff, following consistent protocols, processes, and policies to ensure that that outcome is going to be similar, irregardless of when or where they have their crisis going through. So I do want to kind of come back and say, look, these P&Ps, these policies and procedures that you create are your opportunity to say, this is the way it needs to be done. And granted, there may not be just one way across the country to go ahead and do it, but I want to be consistent. I want to train to those then consistencies, and I want to ensure that I'm matching up with the benchmarks that I anticipate for myself and for my teams. This is your program. So if I ask you if you've got a good program or a bad program, everybody tells me they got a good program. But when I don't see that you've got policies and procedures in place, or they're poorly written, or worse yet, I see this a lot, they're actually memos that get sent out. April 14th, 2021. As of today, we are now doing this. And there's no coordinated organization underneath it or behind it. I do know that that's a program that is on a very basic level, not performing as well as it could be or should be. And once again, we're doing sacred work. Policies and procedures suck to create, but you've got to have them. So let's go ahead and move through. So work that I've done, and I won't tell you the county, it's a California county that we're working with. We're supporting them in policy and procedure development. And really what we did is we've got a list of what we think are all the policies and procedures that you need. You can have certainly much more than we've got, but there's some that you absolutely need. You need to have a focus on. And as we were starting to write them, we wanted to go ahead and get them up and running fairly quickly. So we start to prioritize them. These are the ones I want to do first. These are the ones I want to do second. These are the ones I want to do third. So high priority ones are going to be this. Program description. I'm going to show you an example of a program description. Most, I'm talking 85, 90% of mobile teams out there do not have a program description. And I'll go through what's in that, but it clearly defines what you are and what you are not. It really goes ahead and gives you focus for what your teams need to be doing out there. And it is a great tool for your new hires to have an understanding of what it means to be a mobile team within your system. Here's what we do. Here's what we don't do. Here's how we do it. This is everything you would ever need to know. I can take that and talk to a funder. I could talk to a stakeholder. I could talk to anybody, and it would fully describe who we are and what we do. How you respond to minors. For those of you who know, the majority of times you're going to get sued in behavioral health is generally related to whether you're working with minors or not. Should all be working with minors. I need to really make sure that my policies, procedures, and protocols are really tight when working with minors. Transportation. So when we're talking about transportation in the SAMHSA guidelines, we do see that transporting voluntary guests when appropriate is a fundamental element that should be going on within mobile crisis outreach teams. Many do not. I'm going to say most do not. I'm sitting now in Atlanta, Georgia. Atlanta, Georgia's got 159 counties. Every county has a mobile team. None of them do transportation. What I can tell you is about 30% of the folks we would see in Maricopa County, probably about 600 times a month, we're going to have somebody in our van driving them where they need to be. Definitely decreases the amount of police involvement. I need an ambulance involvement, but you need to have a policy and procedure when it's appropriate, when it's not appropriate. You know what my staffing model is going to go ahead and be, where I sit my guests, or I sit my clients, or I sit my people. You should have something about transportation. Even if your policy is we don't transport, then you need to document that we don't transport. Executing a duty to warn. We've all got degrees. We've all been in the field. We know how to do a duty to warn, or do we? What is your policy? What is your agency's policy? What is our documentation for that? When do we do it? When do we get supervision about doing that? If left to my own devices out there, I may do it right. I may do it wrong. I may violate HIPAA. I need very clear understandings of those things. Law enforcement interaction. What we do anticipate is that a lot of your mobile teams out there are either embedded working with law enforcement or frequently responding to the same calls. You're either calling them or they're calling you. How do I work with law enforcement? I should have policies, procedures, and protocols around that, because every time I bring law enforcement in, I'm bringing in a different culture with a different set of protocols, a very highly specialized set of protocols. I want to make sure that my protocols match up so that we're communicating very well. How you guys do 5150s, 5585s, mandatory reporting and risk assessment. Those are high, but in addition, additional ones that we think are high, and when we jump to the next one, are going to be how we get consent, how we do our mandatory reporting, our confidentiality rules, regulations, not just following HIPAA, saying agency ABC always follows HIPAA guidelines. That's a policy, but how do we do that? What forms are we utilizing? When do we utilize that within the assessment itself? How we respond to dispatch, how we coordinate with higher level of care, which could include what documentation are we giving them? What releases are we signing? Where are we dropping off? What communication do we have? How do we handle problems? All of those. How do we manage our language? Are we using language lines? Do we have a sign language interpreter that we can go ahead and call in? What's the phone number for that? Is it 24/7? Is it not? How we do harm reduction and how we do refusal of service or unable to find. So I want to kind of highlight out of all of these, the one that I see frequently being problematic from a conceptual viewpoint is refusal of service, unable to find. I'm going to say the majority of times I go and I talk to a mobile crisis provider and I ask, so what do you do if you go out on scene, someone tells you to go jump in a lake immediately? What do you do? And we get different answers. Well, we're going to engage in 3 different ways. We're going to back up. We may ask for another team to come on out. We're going to sit close by, present. We're going to try to evaluate signs and symptoms from afar to determine if we need to bring in other folks. Or we just ask them, are you sure? They say no, and then we just drive away. Most agencies don't have this policy. If somebody is refusing to talk to them, or if they're unable to find, they kind of feel it's not a client, right? I don't have a consent. Person doesn't want us to be there. I don't have a clinician or a therapeutic relationship with that person. And if we just drive away, we've got really no liability because we don't have a client professional, relationship, and we don't have consent. What I will say is if you go out and you see somebody and you're able to eyeball them and you just drive away and that person hurts themselves, you still got some liability. I mean, we're in the US on a very horrible kind of way to think about things. You can get sued for absolutely anything. We've seen it. You guys are in California, you get sued more than anybody in California. Everything from employment to, to service provision out there. If I see somebody, my eyes as a licensed clinician is assessing. I'm assessing whether they're disheveled or not. I'm assessing whether they're apparently attending to internal stimuli. I am attending to whether or not they've got open wounds on their arm. I'm attending to whether or not their eyes may be dilated or not. There's a lot of things that I'm starting to see. So saying they refuse to talk to me and I drive away doesn't mean that you don't have enough information to warrant first response to come out or look at some other option to ensure safety for that particular person. So what I can say, all of us are going to be in a situation, if we work in this field long enough, that somebody we're working with is going to die by suicide. Saying that we saw them, but they refused to talk to us, so we didn't do a full assessment and we left, it's going to come back to, what did you see? Could you have made a reasonable prediction that this person was in imminent danger to self or others? Did you have a duty to warn? Could you have brought in law enforcement because of those concerns? Or if I don't have an assessment, what do? I need to have these types of policies in place of what I do. If I'm unable to find, I call my referral source, I let them know I can't see, I drive around the area for 20 to 25 minutes looking, and then I notify my dispatch unable to find, and then we have them go ahead and follow up with the original caller. That's absolutely fine. But coming out and someone telling me, get out of here, and they're obviously impaired, psychotic, tending to internal stimuli, got a knife on the phone book, all of those things, I can't say, not my problem, because they refuse consent. So let's keep moving. These are the high priority ones. These are the medium priority ones. If I was going to focus on creating from start, I'd go ahead and focus on my high priority ones. Things like billing, how do we go ahead and bill? Make sure that we've got policies and procedures in place for everything that needs to go on the chart to make sure that we're billing. Got to be sustainable. If I'm not sustainable, no money, no mission, starts to kind of go away. Supervision on scene. Supervision on scene for me is, when do I call my supervisor because I'm scratching my head? When do I get additional backup about what my treatment plan is going to go ahead and be? When do I ask for help? I clearly delineate that. Because quite frankly, if I've got 2 professionals looking at a situation the same way, it does create a lot of safety for me. But I always want to go ahead and make sure that if I'm in doubt, I'm not making a decision that I'm not 100% on or that another person hasn't commented on. Documentation requirements, what's going to go into your record, what's not going to go into your record. How we respond to schools. Are we going to check in with the front office? Are we going to identify ourselves, and where we're coming from? Are we going to request the child by name? Are we going to just say, we've received a phone call? Do you know what's going on? Are we going to have school officials there while we do our intervention? These are all things that you think about in your program, but you want that consistency. You don't want a school to call you and say, how come Jamie did something dramatically different than, the person who came out here last week for a different person? How do we coordinate care? If I'm sending somebody to an outpatient clinic, are we calling and trying to make that first appointment? What releases are we getting signed? What training standards do we have? So if they're starting to hire in, having a policy, the policy states all our staff are trained in trauma-informed care, cultural competency, risk assessment. Our protocols are going to go ahead and be the list of things that they're trained on, and our procedures are how we get them through that training. I do need training standards. At some point, if you do have an adverse event, you want to be able to come back to saying, my staff were trained, here's our training policies and procedures. How we do on ongoing supervision. Are you meeting with your teams once a week? You meeting with them individually once a week? You meeting with them as a team once a month? Are you documenting that? What goes into that documentation? The policy is everybody gets supervised. The protocol is that they get supervision individually 3 times per month and as a team once per month. And the procedure is we document on the staff supervision form countersigned by A, B, and C. Team composition. I do think it's kind of important to go ahead and say what should your team be. If you are following SAMHSA's national guidelines, my team is a licensed clinician and a paraprofessional, either a BHT or a certified peer support specialist, whatever you decide, but this is what my team composition is going to go ahead and be. I do think it's important to have acuity guidelines. And acuity guidelines are really kind of talking about when people are at certain levels, they're going to go certain places. High acuity, facility-based services. Low acuity, outpatient, community services, some form of connection. Moderate acuity, what are we going to do with those folks? So we can jump one. Specialty populations, do you have special protocols if you're working with veterans? So in Maricopa County, we call the veterans line here in Maricopa County. They have access to better services if we go through that. We get permission before we do that. Intellectual and developmental disability, special populations. We've actually got special teams that will work with that population. If not, we have BC board certified behavior analysts that we can go ahead and call just to get consultation with to ensure that the work that we're doing is going to be appropriate. How you do follow-up. Do you have a 1-day follow-up, 3-day follow-up? Is it the team that went out? Is it other people? What do we do? How do I deal with bed bugs? Well, I'm going to throw all of your clothes in the washer and dryer we have back at the ranch, but what is your process for that? Incident reporting, your agency should have that. HIPAA, your agency should have that. Document retention, agency should have that. Communications, how do we communicate with the various people in our world? So communications for us could be, do we have monthly meetings with the local jurisdictions of law enforcement, just to ensure that we're communicating back and forth? How do I handle if there's a weapon on scene? How do I handle if I'm trying to transport somebody and they want to take a 90-day supply of their medication with them? What do I do if somebody hands me their crack pipe? I kind of need to have this nailed down. Obviously, I don't want my staff out there taking possession of syringes and not knowing exactly what they need to be doing with those syringes, or deciding that 3 different staff have been in that situation, they do things 3 different ways. And disposition codes, if used. So really, when we're talking about disposition codes, this is old school. You may not actually need to do that with some of your current electronic health records, but what I've seen work in a lot of communities is this. So at the end of the year, end of the month, you've got to go ahead and you've got to create your reports. So if my disposition code is a 1, and 1 for me correlates to I dropped this person off the emergency department, and 2 is I've community stabilized this person, allowed them to remain in community. And 3 is I've taken them to the crisis receiving center or the urgent care center or the crisis stabilization unit. And the level 4 is that they refuse treatment, but we're safe to go ahead and go. If 5 means that we call for police backup and they took somebody, where they needed to go. Then at the end of the month, I can just go ahead and start doing some data analysis and say, well, I had 42 ones and 107 twos and 63 of this. It becomes very easy to start to do your report. So if you do have disposition codes to simplify your reporting, then you've got to go ahead and document that somewhere so that you can train to it as well. And what we would look at, like I said, level 4 was community stabilized. And then basically the number is where I sent them to. So 4.1 maybe Catholics, community stabilized, refer to Catholic Social Services. 4.2 might be community stabilized, refer to Arrowhead Behavioral Health Counseling. And then you might have 4-97. But at the end, you can really start to do some of your reporting based on that. And there's a couple I would say are kind of low priority. Probably still want to have them. Probably don't need them right off the bat. It's going to be dress code. Then you're going to have to really kind of think about, what am I doing with the vans? How are they checking out a van? How are they dealing with a dirty van? What do they do if there's blood in the back of the van? Do you require that your vans go out with water, especially during summer to give out, or blankets during the winter? So how are they ensuring that things are getting stocked? And even things like where are you keeping your insurance verification in your van? What do you do if you're pulled over? Those kind of things. Now, the dress code, I want to talk about it briefly because there's 2 schools of thought of them. I think they're both legitimate. I do think you need a dress code. Even if the dress code is no closed-toed shoes, even if the dress code is clothes clean and in good repair, I need a dress code. Now, the variations for dress code to me come this way. And in Maricopa County, 2 agencies running these types of programs, we had dramatically different views on this. My view, Jamie's view, is I believe your staff should be in a polo shirt that can identify them as professional. Now, I'm not saying they need, and I would not want, clinician written on the back or crisis worker written on the back. Something that maybe is very subdued, maybe just a small logo of your agency, over your right or over your left pocket, but something that identifies to the community, i.e. law enforcement, that you're not the guest being served or the participant being served. Now, initial research, and granted it's not overwhelming, but there's not a lot of it about this, is that it does improve staff safety when police can easily identify who's who as they're coming onto scene. So from a safety viewpoint for your staff, having a black polo or a maroon polo that as cops are coming on, they know who's who immediately is helpful. Conversely, the other agency, they believe that dressing like the folks that are in crisis dress improve the ability to go ahead and create a therapeutic alliance, which certainly does increase a whole host of other issues. Kind of back and forth. And quite frankly, I don't know which one's best. I know I put folks in polos. I never had to worry, quite frankly, about what they were wearing. Yes, you can wear jeans in dress code. You're going to be sitting on some really gross couches. I'm not going to make you wear slacks. I want closed-toed shoes. You can wear jeans or khakis. You can wear your polo shirt. Everything's got to be clean and in good repair. And if I'm requiring you to wear that polo shirt, I've got to buy you 1 per year for every day that you work per week. So if you're working 5 days a week, 8-hour shifts, I'm buying you 5 of them every year. If you're working 4 10s, I'm buying you 4 every year. If you're part-time, maybe you get 2, depending on how many shifts you're working. So these are the policies and procedures I think you need to have. Once again, how you go about creating them, what they actually say as far as your procedures are really going to be reflective upon what you see as important for your particular team. But you have to have them. If you don't have them, you don't have consistency. You've got folks out there working, using their best judgment in every case, which is generally going to be okay, but periodically it's not going to be okay. And if you see thousands of people a year, and you should be seeing thousands of people per year, if you've got over 150,000 folks in your community, you really want to go ahead and make sure that you've got that consistency that's kind of kicking in. So I think what we can talk about a little bit now is taking a look through some of the draft policies. So what I do know is that we have spent time here at RI, policy and procedures, like I said, they're not fun to go ahead and create. I know they're not fun to create. And if you're creating them by yourself, sometimes you're not sure if you're missing things. So you don't really feel like I've got a great policy and procedure. It's the last thing I want to go ahead and do. So RI, what we do is just part of our consulting is, we kind of create policies and procedures and translate them for individuals and say, oh, these are the elements that we think that you need. The toughest one that I'm going to go through today, and we kind of take a peek at this, is going to be a program description. So as I mentioned, the first thing I put in the high priority is I need to be able to describe what my program is, what it's not. I need to be able to have this so my staff know what they should be doing. The community knows what we should be doing. It highlights to my funders if I need to go out there and get grant funding of what we're doing. And you're going to see this, frequently where we're going to run it in purpose, policy, and description. So this is a very generic one, but it is one that has been kind of used in multiple kind of areas. And you can start to take a look through of what we're doing. We're utilizing this, we're providing that, we're doing this. Our goal is to go ahead and do that. But then as we start to come through, you're going to see we've got other things that are going to be in place there as well. Who we're going to go ahead and see, and if we stop there for just a second, Andy, appreciate it. Eligibility for services. The crisis department will provide mobile crisis services to persons within service area. So once again, if you are a county or a city or some geographical location, I'm going to put within ABC County, priority be given to those who are primary crisis victims, secondary priority clients, secondary victims of crisis due to family and other indirect problems. That's fine. You can go ahead and clean that up and say, crisis will provide mobile crisis service to person within service area in a current behavioral health or substance disorder crisis. Okay. Intervention teams will respond to all crisis intervention from authorized requesters. Can then define what an authorized requester is, probably 911 and AMBO. Staff are obligated to report any, sexual abuse, minor, boom, I've got that stuff in. It's important to say where your headquarters is. It's important to say your hours of operation. It's important to say that your population is, and remember, SAMHSA says your population is everybody within your containment area. But I have seen agencies that work with children and adolescents, our population is children, youth, and TAY populations up to 25. Our admission protocol. How do we know that we're going to serve somebody? Generally, it's because we're going to get dispatched. You call this, here's what's going to happen. Outcome service, design, all of this stuff is fairly generic. But like I said, it describes what your program is and doesn't. So let's go down a little bit more. Like I said, if you've got a model that you're utilizing, so family system perspective is what they utilize in Arizona. Crisis intervention provided on a daily or as needed basis to stabilize. Generally, crisis interventions involve 1 to 3 sessions, but may extend longer. You may just decide the crisis for you is just 1 session with no follow-ups. That's fine. What is my staffing? What is my language capabilities, which is anybody, anytime, anywhere? All of these types of things. I do like having a philosophy of mobile intervention teams. And if we go by SAMHSA, the philosophy is we'll work with anybody, anytime, anywhere with a behavioral health or substance use disorder with a goal of teaching them the skills, resolving their conflict, making them more resilient in times down the road, diverting away from emergency departments and jails. Whatever you decide is your philosophy for your mobile teams, but you need to go ahead and start to get it documented, because once it's documented, your new staff coming on will start to understand what it means to you and what it means to your agency to provide these types of services. If not, they're out there kind of doing that on their own. So let's just kind of keep going through. So that was program description. Here's just one on law enforcement. Once again, purpose, policy, procedures. Here's the purpose, here's the policy, which is the overarching thing. These are procedures that we start to jump into. So it is obviously of utmost importance to have a collaborative community partnership when serving. We're going to train our team members to include all team members who receive regular supervision and engage in conversations regarding the collaborative relationship with LEO, which is law enforcement officer, if you don't. On-scene coordination, if police are on scene, We should be quickly releasing them from scene. If the team is calling them, we're going to easily articulate quickly why we called them there and what we've seen. And all clinical guidance will be provided by the on-call supervisor. Really, anytime that we're going to bring law enforcement in, a lot of times you want to talk to your supervisor. This is why we're bringing them in, or this is what we've seen when we got out there, or here's the fact that this officer yelled at me or is unhappy. I need to go get some support right now. So very generic, but it is there. Safety planning and assessment and safety planning. So once again, the policy is that you're conducting assessments, you're trying to identify appropriate services, and that you're identifying what the risk is. Everybody gets that. Procedures that we end up doing that. So as you're kind of coming through, these are the tools we use: assessment, safety planning, treatment planning. Here's the things that go into our initial assessment. These are the things that go into our substance use assessment. This is what goes into our risk assessment. And like I said, I've said it before, I'm going to say it again. For your risk assessment, you should be using the CSSRS, or the Columbia Suicide Severity Rating Scale. It is common, it is evidence-based, it is easy to use, and it is free. So utilizing your own that was developed, 12, 13 years ago by a clinical director that's no longer there, probably is not going to protect you as much as using something that's standard of care across the country. So risk assessment, safety planning, how we do safety planning. Once again, I'm going to say use the Brown-Stanley. Stanley Brown, sorry, it says Brown-Stanley there, but Stanley Brown. Suicide risk protocols, absolutely. This is really clearly defining what we're doing. So I don't have a clinician saying, well, I did a risk assessment. Which risk assessment? I did my own. I've got a master's degree. I can assess somebody. And I did some safety planning with them on a couple of different things. Now, this is exactly how we do it. So this is just how it focuses. It goes on purpose, goes on policy, then it goes on either procedure or protocol, really kind of all the same on some basic level. But this is the focus that we've got. I mean, go ahead and look at it and adjust as you need for those ones. And know that we can kind of even support through the technical assistance and maybe some other ones if you need it as well down the road. But you're going to tailor those. These are very generic that you're going to tailor to what you need to have, but they're starting points. They're really starting points. And your policies and procedures should be unique for your agency, should be tailored to what's important for you. But once again, you shouldn't be thinking, I need to create all these from scratch. There are a lot of mobile teams out there with very good, strong policies and procedures. And quite frankly, we should co-opt and steal as much as you possibly can, tried and true. So let's move into some tips. So I want to kind of focus a little bit that your policies and procedures should be constantly evolving. I go into a lot of mobile teams, look at their policies and procedures, and I see the last date that they were updated, was a decade ago. And that's not an exaggeration. I've seen some in the last year and a half from the 90s. PMPs constantly evolve. Now, granted, they're not going to always change, but I do recommend that every March or every July or every December during your Christmas break that you review them and update them. And what I noticed is when I'm going through them every year, I'm updating 25 to 50% of them. And it's not big, huge changes. It's small changes, but I am updating them and keeping them current. What happens then is if I do have some sentinel events, if I do have some significant problems, if I do have anybody coming in and poking their nose in, they see that the policies and procedures are frequently reviewed and updated. They know you're using them. They know it's important to you. You see a policy from 1997, and that policy means nothing. Nobody's looking at it. It's the same thing we see with mission and vision statements in a company. When was the last time you looked at your mission and vision statement? Probably during the 4-hour strategic retreat that we created it. I've got to keep my policy and procedures going. I've got to keep them moving forward. I've got to keep evolving them. I've got to get my staff involved with them. Now, what I will say is a very good public relation tool is start creating what we would call collaborative protocols. You're going to consider doing co-design. So when you're thinking about, I do want a law enforcement interaction protocol, I can create it myself. You can create it yourself. You can certainly do that. But what if I go ahead and I bring in the CIT liaison for the county and go ahead and we develop it together, or we bring in patrol captains from across the county to go ahead and just talk about what do they need, what do we need coming on scene. And now I've got a collaborative protocol. Now we're integrating, right? Now we're strongly integrating. We know what they need, they know what we need. Everybody signed off on it. There's going to be a lot fewer problems in the field because we know we have their brass support, and they know that we have that they have our support on that. Schools. Every time I'm going into a school, I want to have a good, strong policy and procedure. But I want to make sure the schools are involved in that, not just what I think the schools need or how it should work, but I want to go ahead and get those co-designs as well. So what I can tell you is if I've got, 40 or 50 policies and procedures, and 7 or 8 of them are really co-designed with the community, I lean on that heavily. I talk to every stakeholder about how we're an integrated program that works with community as evidenced by our collaborative protocol design. We're not just doing what we think is best. We're working with the community on what is best. You want to hard-bake policies and procedures into every supervisory interaction. I can't tell you how easy it comes or how easy it becomes to be a supervisor when you can say, so what does the policy say we should do? You get that call at 2 o'clock in the morning, I'm out here, I'm not sure what to do in this particular case. What does our policy and procedure do? I'm not sure. Well, let's review it. Let's go ahead and take a peek at it. Let's make sure that we're following it. We want to consider which policies need review by your general counsel. Anything that has potential to go sideways. So things like HIPAA and confidentiality. Well, I want to make sure that my lawyers look at that. What I'm telling people to do to ensure confidentiality better line up with what the HIPAA regulations say. Granted, like I said, this is how you view it, but there are certain things that are going to get you in trouble if you don't. So you got to consider which policies and procedures you're going to need review by your general counsel, which ones might need review by your board. What do you have as an agency as far as creating this? And what I have seen is if I'm creating policy, generally, I'm going to have my board of directors sign off on it. If I'm creating procedures, I generally can do it myself. But if I'm trying to attach them together, which is probably the strongest way to do that, it is going to get run through my board. What I can tell you is when you're constantly updating policies and procedures, your board generally does not get annoyed with that. They like looking through because once again, that is your program. They feel they fully understand that, but they also then understand that you're keeping an eye and to attention of what's going on. And I always like to create new policies and procedures when novel situations arise. So some of you have probably been doing this for years, if not decades, and it probably isn't happening often where you're scratching your head going, yeah, I'm not sure what we need to do with that one. But once you run through something that's fairly novel, document it, write a policy and procedure. So the next time it happens, even if it's 5 years from now, you can at least have a game plan of what you're running into. It's always nice, again, to tell your staff, what does our policy and say about this very unusual event that's kind of coming through? So I think that leaves us a few minutes for Q&A. I do appreciate the time today. Like I said, this is, other than billing, this is probably the most boring type of presentation you can give is on policies and procedures. But if you got questions about what might go into a policy and procedure, we probably got decades of experience on the call right now. We can figure it out.
While people are thinking about questions, I was thinking that out of all of the sessions, I know that you've mentioned this is probably the most
The driest.
Yeah. However, I think that this offers gems that we need, when we're working in the field to have these templates. That is gold. Like that is so valuable to have. So we really appreciate you being willing to share those samples with us. Because like you said, why start from scratch? Let's look at what's been done and then build from there. So I really appreciate you making those available to the participants.
Yeah, and there's starting points. It's okay, these are the things I need to be thinking about. How I do it may be dramatically different. You may change 90% of that. But as far as the flow and some of the ideas in there, you just need to extrapolate or translate for your particular communities.
And I love the point that you made to incorporate that into supervision and into interactions, because I'm thinking it does make it so much easier when there is a system that is secure that we can rely on. Because when we're asking team members to do such important work, and without that, it can feel, people can have hesitancy, and it can lead to so many different problems. So I appreciate that. I will go to our last slide, which just leaves you with our email, our phone number, our website. Also, we are on Facebook, Instagram, and Twitter. We invite you to follow us there. And you can also sign up for our newsletter on our website or with this link here. And that will allow you to get information in your email addresses. Thank you so much for being here today. Thank you, Jamie.